Back to our channel. We are in renal physiology. So today we are going to start our introduction part, that is our functional anatomy of kidney. So first we have here the functions of renal system. So mainly everyone knows the main function of our renal system is the excretory function. So what it excretes? Mainly it excretes the metabolic waste like a urea or creatine, and also it excretes the drug. The biotransformation goes on in the liver mainly, and later even that after that the toxins and the drugs which are released back into the circulation, they are filtered out by means of kidney, so that they try to excrete the metabolic waste like urea, creatine, and they excrete the drugs, they excrete the toxins. Next, coming to the regulatory function, they are useful for water balancing, for electrolytes balancing, acid base balance in a body, and also the kidneys, they maintain the arterial blood pressure. And also they have the endocrine function, like they produce different kinds of hormones like prostaglandins, erythropoietin, we'll say different types. And also they have the metabolic function. So you can see kidney, everyone think only about the excretory function, but behind you can see there are very different kind of functions which are maintained by kidney. So now let us see what is the gold standard test to know the renal function. So actually remember creatinine is a gold standard test to know the renal function. So because the urea level goes up not only for the kidney dysfunction, but also in the case of diarrhea, sweating, urea gets concentration. So it is not a specific indication. So many of them think urea is a specific indication for the kidney failure or renal failure, but because you can see the reason here, urea is also rising in the case of kidney dysfunction, diarrhea, sweating. So it is not a specific indication of a kidney dysfunction. So always the golden standard is a creatinine. So you are having the 1.1 million nephrons in each kidney. So two kidneys together you will have like 2.5 million nephrons. So it is made up of epithelial cells, and hepatobiliary and renal system can get out the highly lipid soluble drugs from the body. From hepatobiliary means by means of our liver, and also renal system we can get out the highly lipid soluble drugs from the body. So they should be converted into water soluble substance by adding a charged molecule, because the lipid soluble drugs always escape by passing through the membranes, because our cell membrane is highly acceptable for the lipid soluble substances. So if they are like in the lipid soluble substance, it is very dangerous because they'll be always escaping but never gets filtered out from the body. So if they are converted into water soluble substances, then they are having no chance to go into the cell, so that directly they will come in the form of urine outside, or also sometimes it may go in the fecal matter. So drugs always escape by passing through membranes and can't get rid of the body, and this process is called biotransformation reaction. So means to prevent that is converting the lipid soluble substances into water soluble substances and allowing them to excrete, that process is called biotransformation reaction. So here both the liver and the kidney play a major role in this. So mainly biotransformation takes place in the liver. So it is of two types. It has a primary reaction and the secondary reaction. The primary reaction is forced to convert into the water soluble. Directly the lipid soluble is converted into the water soluble. Here it is forced reaction. Whereas the secondary reaction is there are conjugation by any kind of polar molecule, especially like in glycose, glycine or taurate. It is called conjugation form of compounds. If then they are conjugation, they are converted into the water soluble substances. So we should understand the normal levels of sodium, potassium which are present in our body, because it's a very useful condition which is useful to save the patient life. So you can see the sodium concentration is like normal. In normal person it is 140 millimole per liter, which is present in the blood, and it's the range may be like about 135 to 145 milliequivalents per liter. And the potassium should be like 3.5 to 5.5 milliequivalents per liter. If the potassium levels are very high than 6.5, then it may lead to hyperkalemia, and if it is low than 2.5, it may lead to hypokalemia. So the bicarbonate level in the body should be like 22 to 28 millimoles per liter, and the calcium level should be 2.5 millimoles per liter, and the chlorine level should be 100 milliequivalents per liter. So these values are very important to remember. Sodium, the range is 135 to 145, and the potassium is 3.5 to 5.5. If greater than 6.5, lead to hyperkalemia, less than 2.5 lead to hypokalemia, and chlorine level is 100, and bicarbonate is 22 to 28, and calcium is 2.5 millimoles per liter. So iron is controlled at the entry point, that is at the GIT mucosa. So already I think we have discussed in a quick revision videos, in a complete revision of GI physiology, I have discussed that how iron enters the cell into the GI mucosa, what happens. So iron is controlled at the entry point, that is GIT mucosa. Whereas the potassium is controlled at the exit points, means the potassium is coming to the body into the blood by means of your food you take, like that. But the exit point, the kidney mainly maintains the potassium concentration, because how much potassium you eat, that much will get excreted, or how much you eat, only some may be excreted according to your body needs and body level of potassium. So kidney maintains the potassium control. So mainly we have the three hormones which are produced by kidney. As we said, the kidney have endocrine function. So of course, if it is endocrine, it should produce certain kind of hormones. So mainly three hormones are produced by kidney. That is, the first one is the erythropoietin. Erythropoietin, which is mainly secreted from the peritubular cells. So erythropoietin is mainly secreted from the endothelial cells of peritubular capillaries. So actually peritubular capillaries are present around our PCT, proximal convoluted tubule and distal convoluted tubule, and they have the endothelium cells, right? So they mainly produce the erythropoietin. And next we have a renin. Renin is produced from JGA cells, that is juxtaglomerular apparatus cells. We will discuss all those. Renin mainly activates, it converts the angiotensin 1 into angiotensin 2. So it is required for conversion. And also prostaglandins are released from kidneys, which are mainly the vasodilators, means they dilate the blood vessel. If the blood vessels get dilated, there is more blood flow and there is less blood pressure. This all we already discussed in our blood physiology and also in our cardiac physiology. Now let us see what are the metabolic functions which are done by our kidney. The metabolic function is mainly to convert the inactive vitamin D into the active vitamin D. So actually always the vitamin D which you are taking from the sun is always in inactive form. It should be converted to the active form, then only it can be absorbed into the body. So how it is converted? Mainly we have the cholecalciferol, which is produced by the skin. It reaches the liver and gets hydrolyzed in the 25th position and then passes to the kidney. So whenever it gets hydrolyzed at 25th position, then it is called 25 cholecalciferol. But then after that it passes to the kidney cells and undergoes one more hydroxylation at one position, first position. So then it is called 125 dihydroxylation. Actually it gets dihydroxy, means one at the one position and also at the 25 position. So and it gets activated in the form of vitamin D. So the activated form of vitamin D is mainly when it passes by means of liver and also next to the kidney. So it should get hydroxylated even at the liver and also should get hydroxylated at the kidney. So only because of two hydroxylations, then only the vitamin D can be formed. So we have an enzyme that is called as enzyme alpha-1 hydroxylase, which is present in our proximal convoluted tubule cells. So it is activated by means of parathyroid hormone. So whenever in a blood we see the vitamin D is low, then it is, the parathyroid hormone immediately activates the alpha-1 hydroxylase enzyme, so that this acts on our this is useful in our kidney to get hydroxylated in the first position. So 1 and the 25 position it gets hydroxylated, so it is called dihydroxylation. So this is active form of vitamin D. So now we are going to see the cardiac output, how it affects the renal blood flow, how the renal plasma flow leads to formation of glomerular filtration rate, how this leads to total flow in the kidney, and how the urine output is formed. So this is a flow like cardiac output, it's 5 liter. From there, how much renal blood flow will take 20%. The renal plasma flow going to GFR is also will be 20%. For example, if 100 of blood flow is going, then the total flow will be at last only 1. We'll see all this, and finally the urine output, how much it will be. So let us start our discussion. So first, the abdominal artery divide into the anterior and posterior artery. So this enter between the papilla as interlobar branches. Remember, first the abdominal artery, of course it is coming from abdominal aorta into the anterior and posterior, enter in between the papilla as interlobar. So abdominal artery into interlobal branches and go between the medulla and cortex, and this is called as arcuate artery. And arcuate artery later enter the cortex. So it later enters the cortex, form the interlobular artery. and from this offshoots come out known as efferent arterioles, and efferent arterioles form a capillary network known as glomerulus. So once let us revise it. First, from the abdominal artery, it is nothing but abdominal aorta to the lobar artery, interlobar artery to the arcuate artery to the interlobular artery finally to the efferent arteriole. Efferent arteriole form a capillary and finally known as glomerulus. So from the glomerulus again the efferent artery comes and it continues as peritubular capillaries. We'll see all this. I'll explain this in a diagram very neat form later. So just first you understand the theory. Next, usually the glomeruli are present in a cortex and the DCT, but the loop of Henle is in the medulla. Remember, glomerulus is present in cortex and DCT. So DCT and glomerulus are in the cortex up to distal convoluted, but the loop of Henle is in medulla. The glomeruli in cortex is called cortical glomeruli, and which is near to the medulla is called juxtamedullary glomeruli. So we have actually two types of glomeruli. One is cortical glomeruli and the other is juxtamedullary glomeruli. Most of the glomeruli are cortical glomeruli. They live in the cortex, that is 85 to 90%, but only few are in the medulla. Those are called as 10 to 15%. So there are connective tissue cells in the glomerular capillary which are called as mesangium. So in between the glomerular capillary, for example, my fingers are glomerular capillary. In between this connective cells, these are called as mesangium. And the efferent arteriole makes 10 to 15 loops in the glomerulus, forms a glomerular tuft. So glomerulus is special because both sides it has efferent and efferent arterioles. So always one side we should have arteriole and one side should have vein, but here two sides arteriole, so it's a very high pressure system. So usually pressure in capillaries is low, but the pressure in glomerular capillaries is very high due to two sides arterioles. So again the efferent will break down into capillaries and join the vein to drain the blood, but this is low pressure because of one side artery and two sides vein. That is in the case of peritubular capillary network. And later this capillary network runs around the PCT and DCT in cortex known as peritubular network. And the veins continue as interlobular. So again as the same flow as they are coming this side, now even they should go in the form of veins. So first interlobular to arcuate to interlobar division, finally renal vein into the draining into the inferior vena cava. So the cortical structures of the kidney are supplied by glomerular and peritubular network of capillaries. In juxtaglomeruli, efferent is not divided into cortical, peritubular, they go deep into the medulla called vasa recta. So always remember the loop of Henle is very long in the case of juxtamedullary. Actually they are not having the peritubular network, they are having the vasa recta. They again come back to the cortex, but remember always the vasa recta is around the loop of Henle, whereas the peritubular capillaries are around the PCT and PCT and glomerulus. So they can come back to the cortex. They play specialized function of blood flow in renal medulla. These vasa recta pass into veins, and in medulla the hyperosmolar high concentration of solutes, that is medullary interstitial hyperosmolality, as it should not be washed away, the blood flow through vasa recta is slow. Actually we need to maintain the hyperosmolality, higher concentration of solutes in the medulla. Why we will discuss later, because so as this area is very highly concentration, the blood flow through this area should be very slow, otherwise that would be disturbed. So that's why they have the vasa recta where the blood flow should be very slow. So now let us start the cardiac output. Cardiac output already we discussed. Heart rate into stroke volume of left ventricle. Heart rate is normally 72 and the stroke volume is 70. So 72 into 70 will get 5000 milliliter per minute. So this is the 5 liter blood per minute as formed. And the renal system takes 20% blood from the heart. It is only 1 liter to both the kidneys, that is only 1000 ml per minute. So here the cells will take about 400 ml and the plasma will take about 600 ml, and the 2.5 million glomeruli in both kidneys and 120 ml of plasma is filtered. By 2.5 million, only 120 ml of plasma is filtered. That is the total glomerular filtration rate. Remember always, the cells will not filter, just they pass and they go away, but the plasma will get filtered. So in plasma the proteins also will not filter, only the fluid content will get filtered. So in that also the 65% is reabsorbed by the PCT and 10 to 15% is reabsorbed by the descending loop of Henle. And remember, nothing is reabsorbed from the ascending loop of Henle because it is very tight part or thick part. And 15 ml is reabsorbed by the DCT and left is only 5 ml. And in that 5 ml also again the aldosterone and ADH they act and they take up the water. So only the final urine output only 1 ml. So you can see under the influence of aldosterone reabsorbs salt and water, and ADH finally, so this 5 ml is converted into 1 ml. So 1 ml per minute urine is formed by both kidneys. So remember, both kidneys only form 1 ml of blood. So almost everything is reabsorbed, but you need to remember 65 major amount of reabsorption is done in PCT, 65%, only 10 to 15% by descending loop of Henle, and by ascending loop and thick part nothing is absorbed, only 15 ml is absorbed by DCD, but the 5 ml remaining is absorbed by ADH and also aldosterone. Only 1 ml is the urine output from both kidneys. So per day about 1440 ml of urine is formed, that is minimum 500 to 3500 maximum, that is a normal urine output per day. If the urine is less than 500 ml, it is oliguria, means very low urea. If the urine is greater than 35 ml, it is polyuria, means you can say diuresis, lot of urine is getting lost. So metabolic waste should be concentrated into urine by kidneys. Healthy kidney concentrates 1200 millimoles in 1000 ml of water. So in a normal person we have 600 millimoles of metabolic waste, means of course you can add it is half of it, so even it will be half of it, that is it is produced per day, means 500 ml of urine water should be present to concentrate the 600 millimoles of metabolic waste. So patients with surgery, burns, trauma, they have hypercatabolism, so produce more metabolic waste, means even the more water should be concentrated, right? So now let us see azotamia. Azotamia, there are no symptoms are seen which in which the blood chemistry is altered due to dysfunction of kidneys and increase of urea creatinine. So see here, azotamia, there are no symptoms seen in which the blood chemistry is altered due to dysfunction of kidneys. So actually here no symptoms are seen in the patient, but the blood chemistry is altered due to some dysfunction in kidneys and increase of urea creatinine. So the major azotamia means you will see increase of urea and creatinine in urine. So azotamia is also associated with renal failure, then it may lead to uremia. So uremia is a condition in which you will see azotamia, that is increase in urea and creatinine, and also renal failure. So by this we completed just an introduction part to our renal physiology. Later we will continue with our other chapters. Before that we need to also see some textbook important points which are not found here. I have found just few points like angiotensin. Angiotensin is a peptide hormone which is a part of RAS system, that is renin angiotensin system, which mainly cause blood vessel to constrict. So remember, angiotensin is a powerful constrictor. If the blood vessel constrict, there is low blood flow, means higher blood pressure. So of course it will increase the blood pressure. And next one which I found is, you know that gluconeogenesis is also one of the function of our kidney. How that process takes place, we will also see that one, right? So, and one more thing about this graph I need to explain. So whenever there is a lot of sodium intake, means if you are taking a lot of salt for example, so if you are taking more salt, then kidney also try to excrete more salt, but only to a some extent. But later you can see the plateau phase, means the more sodium retention, there will be more sodium retention in your body, even though the kidney excretion is increased to a some extent, but later it will undergo a plateau, means the sodium is increased in your body, means the internal environment in your body will get disturbed. But later as the this sodium which has increased, it itself will trigger again to lose more of sodium lost in the urine, so again leading to sodium loss. So this is the mechanism, and here you can see the extracellular fluid volume, and this is the time in days, how many days this continues the same process, you can see here. And next we need to see the gluconeogenesis process. Actually kidneys synthesize glucose from amino acids and other precursors during prolonged fasting. So when you are in fasting, kidney synthesis the glucose from amino acids, because there is no glucose in your body now as you are fasting, right? So this process is called gluconeogenesis. So this is how kidney is involved in gluconeogenesis. It can produce the glucose. So here you can see the kidney's position where actually they are present. So you can see the right side of the kidney, not right side, left side of the kidney is somewhat higher than the right side, and you can see the ureter which is coming from the hilum, and it is closing in a bladder and comes out as urethra. So here you can see the nephron which is present in renal medulla. So actually this is the cortex, inside we have medulla, in the medulla you have the first one, renal pyramids. Renal pyramids go into the renal papilla. From the renal papilla you can see this is the renal pelvis. In above the renal pelvis you can see the major calyx, and above the major calyx you can see the minor calyx. So the nephron enters into minor calyx, major calyx into the renal pelvis, from there into the ureter, and finally empties into the bladder. And this you can see, this is the capsule of the kidney. So we have covered everything, right? Nephron in an enlarged view, you can see here, this is the nephron, this short one. So the nephron function unit, so this is what I said, I will show you that how the blood flow to the kidney. So you can see first we have, let us discuss about arteries. So first the renal artery will divide into interlobar arteries and veins. After interlobar it will go into arcuate. After arcuate you can see these are the small branches, it will go into interlobular. After interlobular you can see here interlobular, later into efferent artery. Efferent artery it will go into the capillary glomerulus tuft and it will come as efferent. So here is efferent. So efferent. So the veins actually travel the same. You can see the renal vein is dividing into this interlobar veins. After interlobar veins into interlobular veins. After interlobular veins into the finally into renal vein, and from there into inferior vena cava. So this is how a nephron structure looks. You can see this is the glomerulus, the Bowman's capsule around it. In the connective tissue you have the mesangial cells, and from here you can see this glomerulus is a PCT, proximal convoluted tubule. After the proximal convoluted tubule you can see this is the loop of Henle. In loop of Henle first you will have the descending loop of Henle, and later you will have the upper one, thick ascending loop of Henle. After the ascending loop of Henle you will have the distal convoluted tubule, and after the distal convoluted tubule you will have the cortical tubules, and after cortical tubules you will have cortical collecting duct. Collecting tubules, collecting duct. So this is the structure. In the cortex what you have, in the medulla you have. So remember, in cortex you will have your PCT, proximal convoluted tubule, and also you will have your distal convoluted tubule. Whereas coming to medulla, in the medulla you will have your loop of Henle and the collecting duct. So these are the structures we need to remember, which are present in cortex and which are present in medulla. You can also once again check this again. And coming to macula densa, actually macula densa is present near the distal convoluted tubule. Near the distal convoluted tubule you will have two types of cells. One is Parkinson types of cell, and other you will have the macula densa. These two together form the juxtaglomerular apparatus, which mainly release the renin into the blood. Why renin is produced? Renin is useful for convection of angiotensin 1 into the angiotensin 2. So here we are going to understand what is vasa recta, what are juxtaglomeruli, juxtamedullary nephron, and what are cortical nephrons. So here you can see the cortical nephron. So cortical nephron means it is present in cortex. So you can see it is having somewhat short loop of Henle, but you can see this is the juxtamedullary nephron, means it is near to the medulla, inside the medulla. This nephron is inside the medulla, and you can see the loop of Henle is very long. This loop of Henle is short, this loop of Henle is long. So this is one difference. And the next difference is you can see this capillary network around this is also around the loop of Henle, but here the capillary network you can see it is only around the proximal convoluted tubule and distal convoluted tubule. So this is called as peritubular capillaries, and this peritubular capillary is only around the PCT and DCT. But this capillary you can see this is called as vasa recta, which is around the loop of Henle, and this vasa recta is mainly useful for concentration of urine. These are the main reference. By this we'll complete our chapter of functional anatomy of kidney. Next we'll move on to the other lessons.